We begin your week taking your questions about COVID-19 and putting them to some very knowledgeable doctors. We were talking to Dr. Michael Gardam, and he's off running things at his Humber River Hospital. So thankfully, Dr. Brett Belchetz is in. Sort of a locum for us, Dr. Belchetz. We'll get to you in just a second. ER doctor in Toronto. He's been on our program so often, but we haven't spoken to him for some time. So it's great to welcome him back. And I want to show you this picture to indicate how timely this is. This is Dr. Belchetz yesterday, his first shift back at work following 2 weeks of self-isolation because of some travel. And you can see how he got ready for his shift, full PPE there. So Dr. Belchetz, welcome back. Great to see you.
Great to see you again. Thanks for having me.
An emergency room doctor in Toronto. Tell me about that shift. I mean, if you've been away for 2 weeks to come back, things have really changed in the last 2 weeks. What did you encounter and what did it feel like?
Well, I'd say a lot has changed. And for me, what was really important was to become familiar with all of the guidelines that have evolved in terms of how we're processing patients, how we're preparing for the shift, how we're putting on our protective gear, how we're taking it off, how we're now using the physical space very differently from how we were using it just a few weeks ago. I spent a lot of time speaking with colleagues before the shift, getting prepared. And then in the emergency room, I will say, there's a feeling of just ongoing anxiety amongst all of the staff. And I think a lot of that comes from the fact that we know a lot of healthcare workers have been exposed. And other than wearing PPE, what's really difficult for all of us is that there isn't a clear explanation yet amongst any of the medical evidence as to why some people get so sick and others don't. So it's not like with many other things that we deal with where we kind of know who we need to worry about and who we don't, and what are the exact precautions to take. There is this pervasive feeling of anxiety that if you make one small mistake during your shift, you could be the next potential casualty.
Isn't that a thing to live with, that feeling that one small mistake? Did you, on your first shift, you were all protectively attired in case you did see someone with COVID. Did you, in that shift, encounter anyone coming in with symptoms or concerned about it?
I did, and certainly there's a number of patients that we did tests on. Now, the tests take a day or two to come back, so I don't have the definitive answers on those patients that I ordered testing on. There are some patients that were in the department that I had to be involved in care with who had already been positively diagnosed with COVID. Now, we do try to minimize the number of staff people that come in contact with those patients. Luckily, yesterday during my shift, I didn't have to do any what we call intubation. So that's when we put a breathing tube down the throat of a patient. So I didn't have to intubate any COVID patients. And that's when we worry the most, because during an intubation, when we're putting the breathing tube down the throat of a patient, that's when we have what's called aerosolization. That means particles from the airway of that patient spray into the air. Yes. And those are the procedures that have made the most healthcare workers sick and get exposed to infection. So fortunately, during my shift, I didn't have to do that. But we do have a number of patients in our hospital that have had to have that happen. And right now, I think a lot of people are asking me, how is our healthcare system coping? I would say right now we're actually coping, but we are at the limits of what we can cope with. So our intensive care unit is full. We have some spare ventilators, but certainly if we see a surge in cases, those will get eaten up very quickly. So it is essential right now that we continue with the social distancing and all of the measures that are out there in the community to stop cases from spiking further.
Flatten the curve in order to avoid that surge and the strain that many hospitals will not be able to deal with. A question from Suzanne. This is a really interesting question because it's COVID related, but not. A family member has been diagnosed with a serious illness, which has made Suzanne think, Dr. Belchetz, about in a normal circumstance, they'd go off to the emergency department, deal with somebody like you, perhaps onto a specialist. But now, when everything is focused on COVID-19, and of course it's within the hospital environment, what do we do if a medical emergency arises that is non-COVID-19 related?
This is one of the questions that we're dealing with all the time. And this is the great collateral damage that comes from an outbreak like this, in that so many people who have other medical concerns are not seeking help or are terrified to seek help. And I'm seeing it left, right, and center. I'm seeing patients who I'm speaking to on the phone or speaking to by video who have terrible symptoms like chest pain or stroke symptoms who don't want to go to the hospital and get potentially life-saving care. So what I would say to people is, if your symptoms at home are things that for any reason you can delay, it's not an emergency. So it's not a heart attack, it's not chest pain, it's not a stroke. If this isn't a true emergency, you're probably better off trying to speak to a doctor remotely. So luckily, many of our governments have instituted emergency measures that allow doctors to speak to them by video, by phone. Look into those options. Those are safer ways to get care, because what we've seen in many other jurisdictions like New York and Italy, etc., is that the hospital is a place where you are going to potentially get exposed and get sick yourself. So even if you come in with a minor problem, you may emerge with COVID. So really important to try to get remote care if possible. But that being said, if your symptoms are emergency of nature, so if you are having chest pain, stroke symptoms, whatever it is, you got to come to the emergency room, because your odds of actually having a bad outcome, if you have a heart attack that's not treated, if you have a stroke that's not treated, if you have an appendicitis that you don't seek care for, your odds are much, much worse from ignoring that than from coming to the hospital.
Great question to begin with from Lorraine Chalmers, saying that she and her husband have been getting the flu shots, the ones that we get annually, ever since they were offered. They've never missed a year. Will this increase their immune system, she wants to know, and provide them with more protection from the coronavirus? Any connection, any correlation?
Well, it's a great question, and it's one that I have heard many times from many different people. You certainly should be getting the flu shot, and it's excellent that you are getting the flu shot, because it does decrease your chance of getting the flu, which certainly still is a leading killer of Canadians, despite everything that we're experiencing with COVID-19. But the unfortunate reality is that the flu vaccine does not provide any protection against COVID-19. These are completely different viruses, and the immune response that you will develop in response to the flu shot just will not give you any protection. So go out, make sure you've had your flu shot if you haven't had it already. Be very thankful that you already have it and that you got it in advance of the flu season if you went out and got it. But please do not have a false sense of security if you have gotten a flu shot. Do not believe that this makes you safe from this newer infection.
Thank you, Dr. Belchetz. Thank you for that question. We also got a great question from Terry Bedard, Dr. Belchetz, wondering about what percentage of people recover if they have been intubated and placed on a respirator, on a ventilator, so the most seriously ill of all of those who evolve with COVID-19. Now, just before you answer, I will bring up the data that Dr. Teresa Tam posted last night. What she said was about 6 to 7% of cases develop serious illness requiring hospitalization. 3% of cases have become critically ill. 1% have been fatal. So those are the latest numbers from the Public Health Agency of Canada. But that recovery figure, that's really important, isn't it, Dr. Belchetz?
Yeah, absolutely. And I'm glad that you put those stats up. This is definitely a moving target in terms of our understanding of the outcomes of this particular disease. So we're looking at data from around the world. We're looking at the tens of thousands of cases that we saw in China. We're looking at the evolving situation in Italy. What we really need to understand is, what are the outcomes for people who were able to receive good care? So certainly in places where the healthcare system was overwhelmed, some of those numbers may not actually be applicable to our situation here in Canada. But overall, what we're tending to see is that of those people who are intubated, so those people who are the sickest, who are no longer able to breathe on their own, about 1/3 of those cases are people that just do not make it from intubation. And the other thing that we're starting to look into is, who are the people that are not making it? So are there specific categories of patients, so older patients, people with specific conditions, that are less likely to survive? And what we are seeing is some amount of evidence, again, this is not conclusive at this point, but some amount of evidence that certainly people who are older, people with underlying health conditions, are those people that are less likely to survive if they do need to be intubated for this condition.
Okay. Let's look down the road to maybe a happier time for everyone. A great question from Anastasia in Baynesville, Ontario. How do we expect the virus will dissipate? We are all self-isolating, so in theory, how does it work, Dr. Belchetz? If the virus cannot find a host, does it just die out?
Well, I don't think that that's what we're going to see. So typically in most outbreaks, you will see a virus tear through a population. All of the people that are vulnerable, who are exposed to it, will get sick. And eventually those people who are able to get over it will develop immunity. And then eventually there's enough immunity that the virus does tend to peter out and you don't see it in a widespread manner anymore. Because of the social distancing that we're employing right now, that's probably not the way that this is going to evolve, because not enough of our population is going to be exposed to this for us to have widespread immunity. What we're trying to do, and the reason for this is because this is such a deadly infection, is to prevent people from getting exposed, because we just cannot handle very huge amounts of critically ill patients to the extent that this would cause if large amounts of people were exposed. But what we're trying to do is to buy ourselves time to develop effective treatments and eventually to potentially develop a vaccine, and also to get to the point where we have testing that is widespread enough that we can start to test large segments of the population so that we are able to very effectively and quickly know who is sick and who is not, who needs to be quarantined, who can actually walk around and actually not worry. And that way we can get to some semblance of normalcy. But I think the end state that allows us to get to more normal living is the development of a vaccine and also the development of effective treatments.